So our final speaker, Dr. Leslie Fecher, is a new colleague of mine. So she trained at all around the country at Hopkins and University of Pennsylvania and recently at Indiana. We were fortunate to recruit her here. Been an outstanding colleague. She's been here in medical oncology. So Dr. Fecher is going to talk about keeping up some of the treatments for advanced melanoma for working. Welcome.
Thank you very much. It's a pleasure to be here today. I'm excited that everybody showed up and my panel as well. So this is going to be just an overview, and I think you probably have heard at least about some of these medicines throughout the morning today, and I'm going to give at least a little bit of a perspective on it. So advanced melanoma, what is advanced melanoma? It's melanoma that's moved beyond the original site, and it can move to multiple different parts of the body or one site. Why does it spread, or how does it spread? It's typically because the cells will break off and move through the lymphatic system or through the bloodstream. And why does this matter? All of this adds up to figuring out what the stage of someone's cancer is and what treatments would be recommended at different points in time. And it's critical for us to understand exactly what's going on. Melanoma is a varied picture, and I think that's the theme that goes on throughout all this. The melanoma itself, which is the cancer, can start in different parts of the body. As you guys have all heard, melanoma, your skin covers quite a bit of surface area, and so you might have met different surgeons in your journey. It can spread to different sites of the body as well. So the pattern of melanoma spread is that there is no pattern that can do just about anything. And there can be differences in the genetic makeup of melanomas, like BRAF or c-KIT mutations, which can influence decision making. And then the people, or what we call the host, can be different as well. Melanoma can affect a wide variety of people: men, women, young, old, healthy, and those a little less healthy. And the immune systems in these patients can be different, and that can impact how the melanoma moves. Melanoma is not one size fits all, and the goal is to match the right treatment with the right person at the right time. The melanoma timeline for FDA-approved agents up until recently, 1975 was chemotherapy with Dacarbazine, and 1998 was high-dose interleukin-2. Since 2011, we have several new drugs that have been FDA approved. And when things are FDA approved, it's not just for the indication, the cancer, but the setting of the cancer, the stage. And sometimes they specify, is it the first choice? Do they have to try another treatment first before we can give it? And we also talk about it as a single medicine versus in combination with other things. So you'll see a couple things that are repeated, such as the dabrafenib, trametinib, where the combination was approved after single medicines alone were approved. And now, if you were paying attention to the news in the last 2 days, the combination of nivolumab and ipilimumab has been FDA approved. I'm going to briefly comment on clinical trials. Clinical trial participation, all treatments need to be vetted through clinical trials to determine safety and whether or not there's benefit. And all those medicines we just talked about being FDA approved are here and available because of the goodness and the interest of patients in participating and the physicians and other people who conducted those studies. They offer, if these treatments have been determined to be safe and offer benefit, they then can become a standard of care outside of a clinical trial. And as you well know, there's a variety of different clinical trials out there. Not all are placebo-controlled, not all are the same medicines, and some of them involve medicines that are already FDA approved, but looking at them for different reasons. And if there's any interest, there are clinicaltrials.gov websites where all clinical trials are registered. So what are the options for the treatment of advanced melanoma? We lump them into a couple big categories. Immunotherapy, which is at the forefront of melanoma and has been for some time. And these are medicines that help a patient's immune system try and fight the cancer better. And some of the ones we just talked about, these are examples of immunotherapies. There's targeted or molecularly targeted therapies. And these are ones where if you think about kind of a telephone cord between the two cells, you're trying to block some of the communication pathways between them. And often these can be guided by specific aberrations that we have to test tumors for. So BRAF for us is one of the most common ones. And this is where the medicines like vemurafenib, dabrafenib, and trametinib would fall. There's also a less common mutation that some of you may have heard of called c-KIT. And at this point, there's not technically an FDA-approved medicine for c-KIT mutated melanomas, but there have been studies of certain medicines that are FDA-approved for other reasons. And lastly, there's chemotherapy, and this is one of the older tools in our tool shed, if you will, but I'm a believer in not throwing out any tools, because sometimes certain things aren't available or not possible for certain people. And these are medicines that are trying to kill rapidly dividing cells. So this is a little bit of a schematic that I think is good to see, and this is the idea of checkpoint inhibitors, and this is where the ipilimumab, the PD-1 inhibitors, or nivolumab, or pembrolizumab come into play. And the idea behind this is your immune system is trying to protect your body from foreign invaders, and we often think about that as infections, but the cancer is a foreign invader as well. And so what has to happen, though, for your immune system to mount a response is it has to get activated, and you can see these active, don't remember, there's not going to be a quiz, but just to give you a frame of reference, there's the activation signals, but then obviously there's checks and balances too, because we don't want the immune system to get revved up against something it shouldn't get revved up against. And so there are these inhibitory or negative signals then that try and calm down the immune system if we say we don't want that going. And cancer, I would say, tries to hijack, if you will, these negative regulators. They're trying to dampen down the immune system's attempt to attack the cancer. So ipilimumab is an antibody that targets this molecule called CTLA-4. It's a blocking antibody, so we're trying to take the brake off the immune system. It's an antagonist of a negative, so a double negative. And the same thing here for PD-1, which is another chemical that tries to dampen down the immune system, and that's where the pembrolizumab and nivolumab come into play. So immunotherapies, ipilimumab, or Yervoy is the brand name. It's an anti-CTLA-4 monoclonal antibody. And in cancer, like we talked about, it is increased, and it doesn't allow the body to see the cancer as something that it needs to attack. And so, again, this is trying to take the brake off the immune system. It's given in the vein once every 3 weeks, typically for a 4-dose course. It's shown benefit in melanoma, but not for all patients, but the benefits can be long-lasting, and this is a theme across the board in immunotherapy, why we often talk about it as a forefront of treatment, is that some of the responses can be very long-lasting. Common side effects are if the immune system gets revved up a little too much, and these can be often at the skin, where you can have rash and itching, diarrhea or inflammation of the colon or colitis, liver inflammation or hepatitis, endocrine or hormonal problems, including the thyroid gland, adrenal, pituitary, or pancreas, nerve problems, and then technically an immune attack on any part of the body. Immunotherapies, including nivolumab or pembrolizumab, these are PD-1 inhibitors that you've been hearing about in the news, and they're being explored in other cancers and are FDA approved for other cancers as well. They're recently FDA approved in the past year for melanoma, and again, the same concept. These are typically given in the vein, again, once every 2 or 3 weeks, depending on the specific medicine, and these typically are continued as long as they are providing benefit against the cancer, and you're tolerating them from a side effect standpoint. Side effects are fairly similar, again, fall into this immune category, where we worry about the skin, we worry about the bowels, the liver. We can also see inflammation in other parts of the body, like the lung and the kidneys. We can also see what we call infusion reactions, which are a little less common with IPI, where you can feel a little bit sick as the medicine's going in, either nauseous, headaches, maybe some fevers. This past week, the combination of nivolumab and ipilimumab has been approved for what we call wild type or not mutated BRAF melanoma. This is where both of these medicines are given on the same day, once every 3 weeks for 4 doses. And then typically nivolumab would be continued by itself after that every 2 weeks, as long as it's providing benefit. The responses and the benefits to the combination do appear greater than what we see with the single medicines, and they appear to be long-lasting, but we're still obviously, the melanoma community is still following these people out. The rate of side effects, while they're a similar category, are increased when we put the two together, and I think that's important to stress. Again, similar side effects, but sometimes they can be more impressive, and then sometimes they can have an onset sooner than what we see when we do the medicines by themselves. I want to take a minute to talk a little bit about the immune-related side effects, because I think moving forward, if anybody does get exposed to these medicines, it's really important to have a good understanding and an open communication with the doctor in charge of you. These are due to the T cells or the lymphocytes that we saw in that prior diagram getting too revved up, and T cells can take a little while to calm down. These can mimic what we call autoimmune diseases like Crohn's colitis or ulcerative colitis and other things in that category. They can be unpredictable in who they're going to affect, when they may start, and how bad they can be. And they typically, if they are bad enough, are treated with high-dose steroids. taking away the medicine alone doesn't make the side effect necessarily go away. And typically the steroids need to be continued for at least a month and then slowly cut down over that time frame. They can get worse if they aren't recognized promptly. And so my recommendation is close communication with your doctor with any side effects is really important. It may be nothing, but it's always good to check in. Immunotherapy as well, and I know Dr. Lau has already talked about high-dose interleukin 2. This is a drug that's been around for a while, and it is a bit tougher. It is given in the hospital setting, where it's given in the vein every 8 hours around the clock, up to 14 doses, as long as somebody is assessed and it seems to be in good enough shape to get the next dose. If not, we skip it and reevaluate. Typically, people end up staying in the hospital for roughly about a week, and then out for about a week and a half, back in for another week, and then we give you a little bit of a break. It does require people trained in how to do this. And supportive medicines are used around the clock to control some of the side effects. Most of these side effects are related to the timing of the medicine, and they usually will wear off as we back off. The most common side effects are swelling, low blood pressure, hence it needs to be done in the hospital, flu-like symptoms, kidney, heart, or liver problems, lowering of blood counts, thyroid problems, and nausea and vomiting. It's not safe for people who have significant heart problems, if they have significant liver, kidney, or lung problems. If there's involvement of melanoma in the brain that's uncontrolled, that's also not recommended. And somebody who's not in very good health overall, this is a little too much. And I thought I would throw in another investigational agent that's been talked about a lot in the news, and this is called telanogene Laharpur, which I'm not the best at saying, and it is also abbreviated TVEC. This is a vaccine that is made from a genetically modified herpes virus. And the idea is that it can try and hone directly into the cancer cells and then make copies of itself and make a chemical called GM-CSF, which is an immune-stimulating chemical. And the hope is that not just at the site of where this is injected, but across the board throughout the body, it can have an effect. And this has shown some benefit in studies. It's injected typically into tumors that are easily on the surface, if you will, so skin and lymph nodes. And it's being evaluated in clinical trials in combination with other immunotherapies as well. Molecular-based therapy is going to focus really mostly on BRAF here, and I've put some of the names of the medicines you may have heard of. These are MEK inhibitors down here, and these are BRAF inhibitors. And then I'm going to throw a little bit of information out on c-KIT mutations, where these are some of the FDA-approved agents for other cancers that have shown some benefit in certain studies. BRAF is a gene that's mutated or abnormal in roughly 50% of melanomas, but this is typically skin melanoma, so this is not as common in some of the less common subtypes of melanomas like eye melanomas or mucosal melanomas. And this is testing that's done on tumor tissue. This isn't a blood test. Targeted therapy, so BRAF inhibitors, names that you will recognize are vemurafenib and dabrafenib. These are pills that are taken by mouth at home twice a day, and typically they're continued for as long as cancer is under control. And these have shown that they can shrink tumors in about 50% of people. Common side effects include fever, some sun sensitivity and rashes, skin tumors. You can see other skin cancers develop as well as benign skin cancers, rare eye problems, joint aches and pains, changes in blood counts, as well as electrical changes to the heart. So typically an EKG, blood work, office visits, and scans are used to monitor people on these treatments. Dabrafenib with trametinib, so a BRAF inhibitor in combination with a MEK inhibitor, is also now a standard of care. And these are all for people with BRAF mutations. And these again are pills. The BRAF is taken twice a day, and the MEK inhibitor is typically once a day. And again, these will be continued as long as things are under control. And the shrinkage rate for these medicines, as well as how long they benefit the patient, typically is longer than the single BRAF medicines alone. Common side effects again, fevers and chills at a higher rate than what we see with dabrafenib by itself. Rashes and sun sensitivity, again the skin growths, but some of the skin rashes are actually better when the two are put together. And the incidence of squamous cell skin cancer goes down with the two together. We can see additional eye problems with the MEK inhibitor added in. We can see some heart problems too. And so monitoring would include an echocardiogram or an ultrasound of the heart in addition to the other ones we talked about. KIT is a gene that has been found to be abnormal in less common melanomas like we talked about. So melanomas that start in the mucosa, ones that are on the palms or soles or under the fingernails, what we call acromelanomas, as well as those from people who have a lot of sun damage and melanoma develops in the background of that. And again, this is testing done on tumor tissue. This is less common, quite a bit, than BRAF mutations. And imatinib, dasatinib, and nilotinib are all medicines right now that are approved primarily for treatment of leukemias, but they have been, some of them, in various stages of testing in this setting. And there are still ongoing clinical trials looking at some of these medicines in this rare subtypes of melanoma. These are typically pills taken once or twice a day. And side effects include swelling or fluid retention, nausea, vomiting, diarrhea, low blood counts, blood chemical changes with electrolytes, rash, fever, heart failure, electrical changes to the heart, and bleeding. Chemotherapy in general has a lower chance of controlling melanoma compared to the immune or targeted treatments, and so typically it's not always considered a first choice option. But that being said, there are some people who are not candidates for these treatments, or they may have had these treatments and it stopped working against their cancer. And so chemotherapy does still sometimes have a role. Dacarbazine is FDA approved for melanoma, and this is an injection given in the vein once every 3 to 4 weeks. Temozolomide has a similar mechanism of action compared to dacarbazine. It would be one or the other, and these are an oral medicine, so these are pills taken at home. And this has the advantage that this medicine does seem to penetrate what we call the blood-brain barrier, the protective barrier around the head. Common side effects include nausea and vomiting and lowering of blood counts, but these are milder chemotherapies than what a lot of people get exposed to for other kinds of cancer. And then lastly is Carboplatin Paclitaxel, which is a combination of 2 chemotherapies. And these are FDA approved for treatment of a variety of different cancers, albeit not for melanoma but used. And they're typically given in the vein once every 3 weeks or sometimes weekly depending on the dosing. Common side effects are traditional of chemotherapy, hair loss, lowering of blood counts and risk of infection, nausea, vomiting, allergic reaction, and then neuropathy or numbness and tingling at hands and feet. In summary, melanoma affects many people in many different ways. There are many new and exciting medicines that are now available, and there's continued development of trying to figure out better ways of using it and better sequencing of medicines. So which do we use first and what do we use next? Talking to your oncologist about side effects early and often is important with some of these treatments, and matching the person and their melanoma to the right treatment is the key to success. Thank you. So I have the privilege of introducing my panel here, and I'm going to let them share whatever they want to share.
My name is Marcia, and I was diagnosed in April of 2012 with melanoma at stage 3 at that point. We had just gotten back from a 7-day cruise, and I had right leg swelling, and when we went in to do some testing, they found that my lymph nodes were enlarged and melanoma had invaded there. Thanks. So I had my first surgery where they removed all the lymph nodes in my groin and pelvis, and they also found a tumor around my greater saphenous vein, which they removed at that time. The drainage tube that she had talked about earlier was in my leg, and we had to wait before I could start treatment until that could be removed, and it was 2 months later, and by the time that we were able to get that out, the melanoma had spread even further. So we were looking into clinical trials, but I could never make the grade. I'd always either have my liver enzymes would be a little high or just something didn't quite meet. So we ended up starting with the Yervoy treatment, and we did that for 3 treatments, and then I started having some side effects from that. And what we looked at were the fact that when we did another test, I had actually spread to my lungs at that point in time, and since patience is not one of my virtues that I've been able to develop, I don't think my anxiety was willing to let me continue with that, so we started with the Zelboraf. And by that time, this was just had just been recently approved for the stage 4. That's why we had to wait a little while, because at the beginning I was still a stage 3, and then I became stage 4 very quickly and was able to use the other medications. Some of the side effects from the double wrap could be brutal at days, but it also reminded me that I was still alive, and that was always a very positive thing. And I did share the side effects with Dr. Fecher, and I started at IU, and I followed her to University of Michigan, because in April of 2014, I had a negative PET scan. So all of the cancer cells that had showed up originally were not showing up any longer. And so that has been my journey. It's been a very difficult, challenging journey, but I've had a lot of faith along the way. I've trusted in my physician, I've trusted in God, and it has brought me where I am. And so I feel very, very fortunate to come and talk to you guys today. Thank you.
We talked a little bit about it not differentiating age or what you do. I worked inside a shop. My name is Tim. I worked inside a General Motors shop for 30 years, but every summer got out on the boat, got burnt, spent time on the lake, did what we wanted to do. In the fall of 2014, my wife noticed a mole on my back, and it was getting kind of weird looking. I took a trip with some friends in Virginia, woke up one morning with a bed covered full of blood because it had ulcerated and broke open. So when I got back, I got hold of my physician. He said, you need to go see a dermatologist. Did that. She said, you want me to take a sample or to take it off? I said, take it off. So they took it off at that time. It was in about my shoulder blade. So shortly after that, they called me. It was probably one of the worst phone calls I've ever gotten, because I was driving down the road and all of a sudden this doctor just says, you got melanoma cancer. I go, whoa. And said, this is a good time? I said, no, I'm doing about 75 miles an hour down the highway right now. And so they said, well, I live in Midland, Michigan, and Midland Hospital is affiliated with the University of Michigan. And so I figured everything was going to happen right there in Midland. They said, no, you were going down to U of M. We're going to set you up with Dr. Cohen. Went down and seen Dr. Cohen, the surgeon, and he right away told me that he was going to do the excision to take out around where the mole was at, and also he was going to do the sentinel node biopsy at the same time. Doing that, they put the dye in and they found one node in my armpit that turned blue. So they took that out, and about 3 weeks later they told me that they had to go and do a full node removal underneath my armpit. So we got that done, and then it says, well, you got to go see an oncologist. I said, okay. So they set me up with Dr. Fecher, and Dr. Fecher and I had an interesting conversation first day, because one of the biggest things that I rely on my faith a lot, and I also rely on my time, my family, but I rely on my time on my motorcycle. And Dr. Fecher says, well, the Harley's going. I'm like, no. I said, she says, what do you mean no? I said, if that's gone, I'm going. Simple's that. I won't see you anymore. So we come up with a compromise, and it's worked so far. I have to wear compression when I ride my Harley. It's not a problem, I wear compression. But I'm doing Remolzab, is that it? Yeah, I'm doing that every 3 weeks. The only thing I've had is some joint pain in my knees. But another thing that we discussed that she had no option with is I used to power lift, and I'm getting ready to do a power lift competition next month. So, as far as aches and pains, it's probably not anything that I haven't had before. Stressing my body with the weights and stuff that I'm doing. I have cut back some, but I can't express enough how it is to be treated down here. Because we talked about maybe going back to Midland, and the treatment I'm getting down here from the staff and the people around here is indescribable. Thank you.
Hi everybody, I'm Lori. story, and I kind of feel like a newbie almost, because I'm kind of just getting started with this journey. Although apparently it's been going on in my body for a long time. I had a spot on my back that I routinely had taken off at the dermatologist since 2006 all the way to 2013. And supposedly nothing to worry about. But then in March of this year, felt what I felt was a lump in my breast. And it was kind of a perfect storm of my doctoring at that time. My primary care physician of 40 years had just retired a few weeks ago. My gynecologist was on vacation. I finally beat on doors and got I've got a lump in my breast, I have to see somebody. So got a doctor to take a look at me, and even that day they had a flood in their office and had to move me to a different time. But I finally got in, and they ordered an ultrasound, and that came back that I had at least 2 enlarged lymph nodes, and I should see the breast specialist in town, which I got in to see a few weeks later. And she did a biopsy, and then she immediately had a family emergency and had to go away for over a week. But it just was an odd deal that was originally diagnosed as breast cancer, but fortunately their protocol was to also send the samples to Mayo Clinic, and Mayo Clinic came back, and all of a sudden I got another phone call, oh, it's not breast cancer, it's metastatic melanoma, which at that time to me, I really knew nothing about it. Is this worse news? Is this better news? I didn't really know. But everyone said where you need to be is the University of Michigan. So I immediately tried to do everything I could to get that referral and get down here, and met. And in the meantime, I was doing a lot of Googling and researching and going, you don't really want to do that before you talk to people who really know what they're talking about, because a lot of the stuff is old, and the old melanoma stuff is not very encouraging. So I was feeling like, boy, this is really bad, and came down here and had my appointment. They did another biopsy on my back because that was the biggest suspect. And then I met with Dr. Chang, and that was when I first heard the word cure, because he said, we're going for a cure. And I asked my husband and my sister when we got out, did he say cure? I thought he said cure, because that certainly wasn't anything that was coming up in my reading. So I started to feel a lot more positive, and we had surgery in June, and then I met with Dr. Fecher in July, and talked about treatment options and interferon or clinical trial. Did a little bit more research, and it just didn't seem to me that you get as big bang for your buck with interferon. For me at that time, it was a year of treatment with maybe some benefits, but seemed like where all the action is with all the new drugs that are coming out. I believe strongly in research, so I opted for the clinical trial, and I just actually started that day after Labor Day, I believe, and it's the IPI versus Nivo. I don't know which one I'm getting, and Dr. Fecher doesn't know which one I'm getting. Of course, we try to guess, but I don't say that I'm trying to guess, but I try to guess. And what amazes me about this place, I also just love the interdisciplinary approach. I like the team approach. Everyone has been fantastic. I feel like I'm just in the right place, and that I'm very fortunate to be here, to have an opportunity to be in this trial. They watch you like a hawk. They want to know absolutely everything that's going on. And I said, geez, my lifestyle up to this point comes with a lot of side effects. I've got a list of this long. And So I'm afraid I'm gonna turn into a hypochondriac or something. She goes, everybody does, everybody does. So I feel like I'm feeling like I may, since I've only had 3 treatments, that I'm having a few issues here and there, but nothing, they've been very mild, and I feel confident that it's being watched very closely, and it's important to me that I'm hoping to be able to continue to work, and I've gotten through 5 weeks of the semester already and 10 more to go, so I feel like I'm moving right along and staying on track with that goal. So again, like everyone here, I can't say enough about the entire staff, and from the surgery all the way, from dermatology all the way through to the oncology. It's just been fabulous. So thank you very much.
Thank you all for participating and reading.